In this video, I will discuss how I decide optimal PEEP level in ICU. This is very interesting topic for the clinician who manages the patient in intensive care unit, particularly in context of acute lung injury ARDS. Here I will discuss with you what are different options available to determine optimal PEEP in an individual patient and what approach I use for my patient. I am Dr. Sunil Garg from Essentials of Acute Care. Positive and expiratory pressure or PEEP has been interwoven with acute respiratory distress syndrome since its first description. The optimal PEEP as the value is associated with best oxygen delivery and dead space reduction. Even though PaA2 continue to increase at PEEP levels higher than the optimal PEEP takes into consideration not only arterial oxygenation but also hemodynamic effects of PEEP. So essentially focus is not on arterial oxygenation but on oxygen delivery. In the early ventilator induced lung injury era, it was introduced primarily to correct hypoxemia, which has now extended to the lung protective strategy where the aim is to keep the lung open and to avoid barotrauma by preventing hyperinflation. So essentially what is optimal PEEP? Optimal PEEP provides appropriate gas exchange, means it should provide viable gas exchange without excessive dead space generation or potentially toxic levels of FiO2. It should keep the lung open, means preventing phagic airway collapse and keep all unstable alveoli recruited. It should avoid alveolar overdistension, so minimizing barotrauma, and it should not compromise hemodynamics. There are various methods to set optimal PEEP and it includes the use of ARDS NAT PEEP FiO2 escalation table in which PEEP is set according to the severity of oxygenation failure. Titrate PEEP according to maximum compliance means set the PEEP which achieves the highest static compliance. This has the advantage of being tailored to each specific patient. Set the PEEP to slightly above the lower inflection point of the pressure volume curve, therefore avoiding cyclic atelectasis. Use a staircase recruitment or de-recruitment maneuver to find the lowest PEEP at which the maximal oxygenation is maintained, and this has the advantage of having a very pragmatic endpoint of SpO2. Titrate PEEP to achieve the lowest arterial minus and tidal CO2 gradient. The PEEP value at which dead space is minimal. Use the transpulmonary pressure calculated from esophageal balloon manometry using esophageal pressure as a surrogate for pleural pressure and adjust PEEP so that the transpulmonary pressure at end expiration is between 0 to 10 cm of water. Using electrical impedance tomography and titrate PEEP to achieve the highest electrical impedance in the thorax, and it means the greatest amount of aerated lung. Use sequential CT scan or ultrasonography to visually determine a PEEP at which the greatest volume of the lung is recruited during end expiration. Using stress index to determine optimal PEEP involves setting of the PEEP to a pressure at which the stress index value is 1, and lastly by manipulating PEEP to achieve lowest driving pressure. As we know now, there are many techniques available to set the optimal PEEP with its own benefits and limitations. There is very diverse population that requires mechanical ventilation, so there will likely never be a technique that is ideal in all patients. In my practice, I use driving pressure to determine optimal PEEP in my ICU because of its ease of use. So, what is driving pressure? I made a video in the past on driving pressure. It is calculated as the difference between inspiratory plateau pressure and PEEP, or it is a ratio of tidal volume to compliance. In the absence of respiratory effort by the patient, it represents the pressure above the PEEP which is applied to the respiratory system to achieve ventilation. So, how I set driving pressure to achieve optimal PEEP? Driving pressure should be measured at different levels of PEEP while maintaining a constant tidal volume. If PEEP is raised and driving pressure decreases. This suggests the higher PEEP has resulted in increased compliance and increased alveolar recruitment. But if PEEP is raised and driving pressure increases, this suggests the higher PEEP has resulted in decreased compliance and hyperinflation. So to summarize, what is optimal PEEP and how we set it? So in conclusion, the optimal PEEP is associated with no increase in driving pressure, or rather decrease in the driving pressure while increasing the PEEP without changing tidal volume, and it achieves the best oxygenation with no or minimal fall in blood pressure. So while deciding optimal PEEP, increase PEEP as long as driving pressure does not increase, provided blood pressure does not fall. Observe the patient and look for arterial oxygenation and arterial oxygen delivery. Here I finish my presentation. Hope you understood and liked this video. I would appreciate your feedback, suggestion or comments. See you in my next video on some very interesting topics. Till then, bye and take care.